Okay, welcome everybody. I'm terribly sorry for the delay. This is Ken Poole, President and Founder of the Melanoma International Foundation. And again, our apologies for technical delay. If you cannot hear us through your computer, you should have a phone number that you can call in and listen to us there. And don't forget, if you do have issues, we always archive our webinars so you can listen to it at a later time. Today, we are pleased to have Jedd Wolchok with us. He's a melanoma specialist from Sloan Kettering, and he's going to present an exciting webinar on strategies in immunotherapy. Jedd has been a true pioneer in immunotherapy, and he was our 2012 Doctor of the Year for good reason. At the end of his presentation for the question and answer session. Jedd?
Well, thank you very much, Catherine. Again, sorry to all the attendees for the delay in getting running here. Just some technical issues that had to be overcome, but we're now very happy to welcome you all. And as Catherine said, we're going to spend a little bit of time reviewing what's known about the use of the immune system as a way to treat melanoma. And to make this more interactive, I'm just going to talk for, maybe 20 or 30 minutes or so, and then we're going to take as many questions as we can. So with that said, Catherine, do I advance the slides, or can someone else do that for me? So my big message, number one, is that this is a time of great hope for patients with melanoma and their friends and families, because we now have treatments that impact the most important endpoint, which is overall survival. And most important, of course, is that, but in addition, the success of several therapies in melanoma has really opened up the field to the investigation of additional new medicines, which hopefully will benefit even more patients. So the pipeline of new medicines coming to treat melanoma is richer than it's ever been. And with that, I have to acknowledge the amazing support and work of organizations like the Melanoma International Foundation and Catherine especially. The grassroots support for patient education and research are absolutely invaluable in helping to move the field forward. A lot of the clinical trials were expedited really because of the input from patient advocates and in fact grassroots organizations like this. So we're very, very grateful to MIF and the other melanoma organizations as well. In addition, I think it's really important to recognize that we wouldn't be where we are today without clinical trials, that we will never get better medicines into practice or combination therapies into practice without proper testing in clinical trials. And so for all those courageous patients and families who participated in trials, we're incredibly grateful. And I think another real take-home message here is to always keep clinical trials in mind. Okay. So I just want to review a little bit of the history of immunotherapy, and the history actually dates back to the late 1800s. The dapper young man on the right side of that picture there is actually John D. Rockefeller Jr., and the lady seated next to him was a girlfriend of his named Elizabeth Dashiell, and she actually died about a year or so after this picture was taken from a sarcoma which was underneath the glove of her left hand there. And it was actually the death of Bessie Dashiell after several rather significant surgeries that in her... Oh, this seemed to be advancing on its own. That's real good. Now, okay, we're back. Okay, so the... Okay. Okay, still now. So the death of Bessie Dashiell actually inspired in her surgeon, who's the gentleman with his arm crossed in the middle of this slide. And her surgeon, whose name was William Coley, the desire to try to find a better way to treat cancer. And Coley didn't have anything really to use for this investigation other than his powers of clinical intuition, his eyes, his hands, and his ears. And he actually came up with that the immune system could use to treat cancer because he noted that patients who developed surgeries, patients who developed infections after cancer surgeries were more likely to recover without the cancer recurring than those patients who didn't have infections after cancer surgery. And he very insightfully realized that infections could be a way to stimulate the immune system, even though nobody knew what the immune system was then. And he went about trying different ways to augment the immune system as a way to treat cancer. And he developed actually a drug called toxins, and this was actually in use until the 1930s, but then it faded out as newer methods of cancer treatment, such as radiation and chemotherapy, became more popular. Now, one of Coley's patients in this next slide, who is a gentleman who had a sarcoma on the neck, which was cured by an injection of Coley's toxins, which were a mixture of killed bacteria, and this was really the clinical research at the time. Now, one of the challenges that we have in thinking about the cancer and the immune system is that to the immune system, cancer looks like the normal cell that it came from. So in the case of melanoma, the immune system thinks that a melanoma cell looks just like a normal melanocyte because most of the proteins and sugar molecules and things like that are really similar. There are only, a handful of really different looking things that the immune system can see. And so the challenge for us as cancer immunologists is to coax the immune system into seeing something that looks like the normal body. And knowing that our immune systems, since the time that we were developing as embryos and fetuses, are trained to ignore the normal body to prevent autoimmune disease, this is a challenge. And this is really why it has taken so long for medicines to be developed that will adequately coax the immune system into treating cancer, which again looks like the normal self. So a quick review of medicines approved in the U.S. to treat melanoma in 2013. And once again, the slides have a mind of their own. Oh, goodness. Right. I'll just hope. Okay. Is that there are 5 medicines now approved to treat melanoma in the U.S. We're really familiar with them. Interesting thing is that 3 of those 5, shown in red here, are actually immunotherapies. So it's very important to know that we already have several medicines in common use, FDA-approved drugs to treat melanoma that are immunotherapies, and we hope actually to have more. Now, the ones, and I'm going to really concentrate most on medicines to treat metastatic melanoma, not talk so much about adjuvant therapy with interferon, although interferon is a valid way to augment the immune system, and it is used in the adjuvant setting to try and decrease the risk of recurrence. The first medicine that I truly believe showed that with proper of the immune system, you could actually cause cancer to regress was interleukin-2, which first tested cancer patients in 1985. And actually, we now know that there is a subset of patients with melanoma and kidney cancer who have essentially been cured with the high-dose interleukin-2. We know that this is sometimes a difficult medicine to give. It requires inpatient hospitalization. It has some significant side effects. But if you look at the survival curves in this next picture, and focus on the blue line on top, which represent the patients who have complete responses with all tumors going away on scans, the amazing thing is that if patients have a complete response that lasts 2 years, they're still in that complete response 10 years later. So that really shows the power of the immune system to durably control cancer. And that, I think, is a major difference between immunotherapy and other kinds of anti-cancer therapy. The immune system is a living, dynamic organ in our bodies. It remembers things. It has special cells called memory cells that are specifically designed to hold on to a response for decades. We know that in the case of routine childhood immunization, our bodies remember those vaccinations for several decades. And so the immune system could be expected to control cancer in a durable way. The challenge with IL-2 really is that even though it helps some people with this disease in a very meaningful way, it really does not benefit as many people as we would want to see it help. And so therefore there was a need to think about other ways to tune the immune system. Can I have the next slide, please? Okay, so fast forward from 1985 to 1995, when a scientist at the University of California, Berkeley, named Jellison, begins thinking about a molecule called CTLA-4. And CTLA-4 is a protein which is found on the surface of immune cells called T cells that keeps cells from getting overly activated. It's, in a sense, a braking molecule on T cells. And it keeps them from getting overstimulated as a way to prevent autoimmune disease. And one of the medicines that now is approved to treat melanoma is a medicine called Ipilimumab, or Ipi for short. And Ipilimumab works by blocking this braking mechanism called CTLA-4. So can you have the next slide, please? So to reduce that somewhat complicated immunology to something that many people can understand, I use this car analogy for how your immune system gets activated. So the cells called T cells are some of the most potent cells in the body for recognizing things that are dangerous and then killing them. And they're mainly designed to kill bacteria and also other cells that have been infected with viruses. But they can recognize cancer cells as well. And they do that with a very specific protein on their surface called a T cell receptor, which recognizes individual targets on invading cells. The T cell receptor meeting its target is not enough to get T cell activated. At the same time, you need to have something that acts like an accelerator pedal, because I think we all know that if you just sit in your car, insert the ignition key, and turn it, the car is not going to move. You need to step on the gas. And so that gas pedal is a pair of molecules called CD28 and B7. And I think we also imagine that if you had a car with ignition on and your foot on the gas, it's definitely going to move, but if you've got no way to slow that car down, then I think the result is inevitable. So you need a brake. And CTLA-4 is that brake on T cells. And what we're trying to do with ipilimumab is to temporarily shift the brakes on this accelerating T cell so that it can become a little more active than it otherwise would be, and perhaps would be able to recognize molecules on cancer cells. The next slide, please. So the study that was done in patients with melanoma that resulted in the approval of ipilimumab was a trial that was called MDX-01020, and it was a fairly large study of almost 700 patients who had metastatic melanoma and who had not had a satisfactory result from a prior treatment. So they had had at least one prior treatment. these patients were randomized to either an experimental vaccine called GP100 or ipilimumab at the currently approved dose of 3 milligrams per kilo once every 3 weeks, given by intravenous injection 4 times. And the other group got a combination of both of those things. They got the ipilimumab as well as the GP100 vaccine. Okay, can I have the next slide? The results of this study were pretty clear that the groups that got the ipilimumab alone or the ipilimumab with the GP100 vaccine are the blue and the green. And the group that got the GP100 alone, the vaccine alone, is the purple. And you can see that the long-term survival of the patients who got the ipilimumab alone or with the vaccine is significantly better than the patients who got the GP100 alone. And best way to try to understand this is using something called the hazard ratio, which is actually the reduction in the risk of death with use of ipilimumab. So for any patient in this study, the chance of them having a fatal event from the melanoma was reduced by about 32% with the use of ipilimumab. In addition, the chance of them being alive at 1 and 2 years was about twice as high if they received ipilimumab compared with the vaccine alone. So, next slide, please. Now, this alteration of the immune system comes at a price. There are side effects that can take place whenever you try to stimulate the immune system in a very general way like this. And these side effects that occur with ipilimumab have been called immune-related adverse events. And they mainly involve the skin and the gastrointestinal tract, and itching, rash, diarrhea, more rarely some problems with some endocrine glands or the liver enzymes getting a little bit high. Most of these side effects are very manageable with the use of prednisone or other immune-suppressing drugs, but it absolutely requires that there be good communication between the patient, family, and the caregiver and the physician so that these effects can be picked up quickly and attention can be paid to them so that they can be reversed. Next slide. An idea of the percentages that we've seen in patients treated in our larger experiences here at Memorial Sloan Kettering. The next slide. Sometimes the responses to ipilimumab are a little bit difficult to understand because the system does not always get activated at a predictable point in time. When we give other kinds of treatment for cancer, like chemotherapy or, say, a BRAF inhibitor, we expect the results to happen very quickly if they're going to happen, because those are therapies that interfere with the ability of the melanoma cells to divide, and we should see tumor shrinking right away. Here, with drugs like ipilimumab and the PD-1 blocking drugs, we are not treating the tumor cells directly. Rather, we are treating the patient's immune system, and the patient's immune system then goes out, seeks a target on the melanoma cell, and hopefully kills the melanoma. And so it may happen quickly, but it also may happen slowly. And so these are pictures of a CAT scan through the liver of one of my patients who was treated in one of the ipilimumab trials. And that big gray organ on the left side of each of those CAT scan images is the liver. And you can see after 4 treatments with ipilimumab, there are many more of those gray dots in the liver than there were when the patient started. And so this would indicate actually that the patient was getting worse. But I walked into clinic that day, and I was going to share, the unfortunate news with the patient that the treatment wasn't working and we should consider something else, when the patient, who was a bit of an outspoken New Yorker, stopped me and said, "Wait, don't tell me what the pictures show. I have to tell you something first," and proceeded to tell me 3 or 4 different ways in which he felt better. And so at that point, I did what any good doctor would do. I turned right around and made sure I had looked at the right CAT scans, and once I convinced myself that that was the case, I went back and asked him to tell me why he felt better. As he was describing all these symptoms that had recently improved, he really convinced me that perhaps we needed to wait a little bit longer, that perhaps the immune system was not going to cause the tumors to get smaller right away like chemotherapy would, or a BRAF inhibitor would. So we basically asked him to come back in about 2 months and get another set of scans with no additional treatment. And can I have the next slide? And no additional treatment, you can see that most of that went away, and it continued to go away. And this gentleman who, I just saw in clinic a few weeks ago, now, 6.5 years after these pictures were taken, doing great. On the trial that he was on, he just continued to get maintenance ipilimumab, which is not part of the standard approval, but because of the study he was on, he was allowed to get it. But I don't even know if he needed that, because he got better between weeks 12 and 20 there without any additional therapy. So I think this showed us a lot about how we need to have a different mindset about judging the results of CAT scans. And we're trying to share these expectations with patients and families as well. Next, please. I think many of you are aware that ipilimumab is really a first step toward medicines that can help the immune system recognize melanoma, and has certainly helped some patients with melanoma live longer. But we also know that the number of people who benefit from ipilimumab is not as high as anybody would like it to be. We need more patients to benefit in a meaningful way. And so ipilimumab served as really a proof of principle that immunotherapy could work, and that it can be a way to really change the course of disease. And this inspired in many pharmaceutical companies the desire to now develop other medicines that target different parts of the immune response, because now, the first really good piece of evidence had come in that proper tuning of the immune system could really deliver in terms of allowing melanoma patients to live longer. And this has led to the development of a long list now of immunotherapies that are being investigated in melanoma, and in addition to other cancers. And in addition to all of these medicines which target different what are called immune checkpoints in melanoma, there are also other strategies like adoptive T-cell therapy, which is a way of taking out T cells from an individual patient's body, either from a tumor or the blood, expanding them, and also potentially altering them in a way to recognize tumor cells better, and then reinfusing them. And some patients treated in this way have had dramatic regressions. Many of these patients had been treated at the National Institutes of Health, but there are other programs going on around the country, including at MD Anderson, at Moffitt, at the Fred Hutchinson Cancer Center in Seattle, and here at MSKCC and other places, to try and see if we can have additional sites that can carry out this somewhat sophisticated form of T-cell therapy. But I'm going to concentrate on now a little bit of this T-cell adaptation with antibodies, and talk a little bit about PD-1 in the next slide. If you use the same analogy of the car, or in this case the train, if ipilimumab blocks CTLA-4 and CTLA-4 is the brake, then PD-1 is the emergency brake, like the little red cord that you pull on the train to stop it. And PD-1 is another protein that's on the surface of T cells. It actually appears after T cells get activated and then exhausted, and when it meets its partner molecule called PD-1 ligand, it actually can cause the T cell to die. So not surprisingly, melanoma cells can actually have on their surface the ligand for PD-1, the partner molecule, and those interactions between PD-1 and PD-1 ligand can actually lead to the death of the T cell that's coming to kill the melanoma cell. So the melanoma cells, again, showing us how creative they can be, have evolved the ability to have on their surface a protein that triggers a death mechanism on the T cell that's coming at it full bore, trying to kill it. So therefore, it's not crazy to think that by blocking PD-1 or PD-1 ligand that we could help the immune reaction against melanoma. Take the next one, please. Shows you a little bit more about PD-1 and does in terms of immune system, and we'll go to the next slide. I think some of you may have seen some of this data. It was all over the news last June. This is actually results that were presented at ASCO by my colleagues Steve Hody and also Suzanne Topalian in patients with melanoma who were treated with an antibody that blocks PD-1. And this is an antibody that's now called nivolumab. It used to be called MDX1106. And it is an antibody that blocks PD-1. It was used in a clinical trial to treat patients mainly with 3 different cancers, with melanoma, with kidney cancer, and with non-small cell lung cancer. And this just shows you some of the data in terms of tumors shrinking in patients with melanoma in 2 of the different groups. And so these plots on the left and the right, the one left shows patients treated with the nivolumab drug at a dose of 1 milligram per kilo, and on the right, a higher dose of 10 milligrams per kilo. There really wasn't any big difference between the 2 doses. And each one of those lines represents a change in the tumor volume in individual patients who are on the study. So it's very simple to read in that the lines that go up represent tumors that are growing. The lines that go down represent tumors that are shrinking. And you can see that the good thing is that there are a significant number of lines that are shrinking. Lines going down indicating tumors that are shrinking. And, I would just point out on the left side there that there's one line that goes up and then comes down, sort of similar to that patient with the liver metastases that we saw from ipilimumab. That patient showed first it looked like the drug wasn't working, but then all of a sudden it started to work. So the same expectation that everything has to get better at a certain point in time, it needs to be put in the background when we're considering immunotherapy. Although I have to say that it looks like responses here to nivolumab happen a bit more quickly and reproducibly than we saw with ipilimumab, a bit more predictable. And from this study and from the subsequent follow-up, somewhere between 25 and 30% of patients with melanoma who were treated with nivolumab did have a decrease in the amount of tumor that they had. And there are subsequent studies with antibodies that I'm sure that you are also familiar with, called MK3475 and others, which have also shown activity of drugs that block this PD-1 pathway in patients with melanoma. Go to the next slide. So this was actually a slide that Jellison had made when he was thinking about how blocking CTLA-4 with ipilimumab would regression of cancer. And on the left side of the slide there were lists of it was a list of ways in which tumors can attract the attention of the immune system. One is that tumors can grow to a point where the center of the tumor dies, which is sometimes called necrosis, and that can often be quite inflamed. And the immune system likes areas of necrosis. It attracts the attention of the immune system because the immune system likes to try to clean things up. But you could also bring immunotherapy together with vaccines as a way to introduce a target, or other forms of more standard anti-cancer therapy, chemotherapy, radiation, hormone therapy, anti-angiogenic therapy, which blocks blood vessels, or targeted pathway inhibitors, which are ways to tumor cells, release the debris from tumor cells, and that would serve as a attraction for the immune system once its brakes had been cut to kind of focus in on the area of cancer. Okay, the next slide. I'd like to give an example of how this might work in a patient that we treated with melanoma who was treated with ipilimumab and then radiation therapy. So this is a 33-year-old woman who had melanoma of the skin. She developed a lung metastasis. She received chemotherapy for that, which did not really solve the problem. She had that lung metastasis removed and then developed another metastasis on the outside of the lung. We'll go to the next slide. This is a series of images from this patient's CAT scan, and up in the upper left-hand corner in panel A, you can see the arrow pointing to this recurrent melanoma, which is in kind of the back surface of the lung, right where the nerves come out of the spine. She also had in that red circle in the center of some enlarged lymph nodes, and then the black arrow is actually just pointing to a funny blood vessel in the liver. The big circle is the organ called the spleen, which in that column A looks normal. And this patient was treated in a clinical trial of ipilimumab from August 2009 until November 2010, and at that point it looked like things were getting worse, that tumor up on the top with the white arrow pointing to is larger. It's causing some pain because of nerve compression, and that organ in the big red circle on the bottom, the spleen, is now getting some dark gray dots in it, which represent metastases. And so because there was pain from that large tumor on the top, we actually asked one of our colleagues to deliver radiation to that. And that radiation was delivered around January 2011, and right after the radiation, you could see that nothing really good had happened yet, although sometimes it takes several months for a good response to radiation to occur. Once you look at that column that says April of 2011, you can see that, of course, the tumor that was radiated up on top has significantly decreased in size. The lymph nodes in that red circle in the middle have decreased in size, and the spleen is now clear. And so this patient remains in this very nice response to this day, and she served as a very good example of how immunotherapy could be combined with radiation in something called the abscopal effect. And this is a word from Latin, which basically means to shoot from a distance. It's basically a term applied when you treat one tumor with a therapy like radiation, and the immune system is properly tuned in the background. Proper treatment of one single tumor could unleash an immune reaction that is able to lead to the regression of even distant metastases that were not in the radiation field. And so because of this observation and some others, we and several other groups around the world have now started trials combining radiation with different immunotherapies, and we're very eager to see whether we can get more responses like this. The next slide. And then, of course, it is not at all unreasonable to consider combining the two approved therapies for melanoma that we know so much about, vemurafenib with ipilimumab, that perhaps you could get additional benefit by blocking CTLA-4 to unleash the immune system at the same time that you turn off the BRAF kinase molecule with a drug like vemurafenib. There are various different reasons why this could work well together. One is that the vemurafenib can kill some melanoma cells, which releases this debris, which serves as a target for the immune system. But second, it's actually known that drugs like vemurafenib by themselves could actually have an activating effect on immune cells, and we're trying to look at that much more carefully right now. The next slide. I think many of you know these are the dramatic responses seen in PET scans in patients treated with vemurafenib. These are patients treated at several different sites in the phase 1 trial, and you can see that this early and profound control of melanoma on these PET scans is very impressive. The next slide. I have to be very careful, to combine these therapies in a rational way. We know from a trial, it says on the bottom of this slide, phase 1 trial of ipilimumab and vemurafenib ongoing. So we actually have participated in a phase 1 trial of ipilimumab and vemurafenib on patients with melanoma, along with colleagues at UCLA and Dana-Farber. We have actually had to stop that trial because of some significant side effects that occurred. And different schedules of those medicines are being considered, because perhaps the best way is not to give them together, but rather to give them in sequence, and that's being thought about right now. So it's extremely important to recognize that just because we have 2 new approved medicines for melanoma that seem to work in different ways, that it's not necessarily the greatest idea to combine them together. And then the last part, that irrational combination on the right, is just to remind us that if we do get approval of a MEK inhibitor for melanoma, that MEK inhibitors actually can have a detrimental effect on the immune system. And so we're going to have to carefully think about how we time different combinations, where if we wanted to introduce a MEK inhibitor with a PD-1 blocking antibody or a PD-1L blocking antibody or ipilimumab, we don't necessarily want to do that at the same time, because perhaps the MEK inhibitor could turn off the immune system. So we have a lot of work to do, and this is why clinical trials are so important. But really, for the first time, we now have multiple medicines that are showing activity in melanoma. And the challenge is to build the best possible combinations, and that's going to happen through clinical trials. The next slide. And speaking of combinations, the other combination that's going on right now is a study of ipilimumab with nivolumab, the anti-PD-1. This is a study that is going on here at MSKCC as well as at Yale. We are currently awaiting some additional information about whether we can expand this trial further, but right now this trial has enrolled somewhere between 70 and 80 patients, and we hope to have some data available soon. The next slide. So in conclusion, I just want to again emphasize that this is a time of great hope. We're learning more about melanoma and how the immune system recognizes it. Many new drugs are being developed based upon scientific progress and understanding what goes on in the immune system at a molecular level. Ipilimumab is an approved therapy. It benefits some patients with advanced melanoma for long periods of time, but it doesn't benefit everybody, and there is room for improvement. The PD-1 pathway antibodies are showing activity in melanoma as well as other cancers, and we are very interested to learn more about them in the clinical trials that are now going on. And of course, combination strategies, that last topic, are where I think the future is. Learning how to bring different cancer therapeutic modalities together into a thoughtful, potent combination is where the field needs to go. And again, to reemphasize our absolute gratitude for patients for participating in clinical trials and for all of you for listening today. Thanks very much.
Thank you. That was wonderful. And I'd like to emphasize again, too, that without patients, we wouldn't be getting anywhere with all of this. I think they have wonderful ideas as well. I love the story of your patient, telling you, to quit with the IPI because, we know our bodies best, right?
That's right. That's right.
Be able to tell you what's going on. So wonderful questions, and seems like everyone's working here, so I will start ahead. My first question is about anti-PD-1 and whether it works well with acral melanoma. I've seen that for the other types of melanoma, such as ocular, is often excluded from the trials. And just wondering, what your thoughts are about that and PD-1 working with the variations of melanoma.
We don't have too much information that I know of yet about the different subtypes of melanoma and PD-1, I think because it's so recent. Ipilimumab we know has activity in the other subtypes of melanoma. How it stacks up compared against cutaneous, I think, is still something that we're looking at. We certainly have seen responses to ipilimumab in mucosal, acral, and ocular melanoma. I think learn more as the PD-1 trials read out, into phase 2 and phase 3.
Well, they're genetically different than cutaneous, correct?
They have different genetic mutations, but I think it's important to know that as opposed to things like BRAF inhibitor, we don't have any strong evidence that the genotype, the genetic mutations that are present in a melanoma tumor increase or decrease the likelihood of a immunotherapy working. It's an interesting question. We just don't know the answer yet.
Right. I know I have patients that are concerned because they can't get into the PD-1 trials because they have ocular. They're excluded. And why that would be?
I think that it is because of the unknown possibility of whether the medicine could work in that subtype melanoma. I don't necessarily agree with it. I think that it's a question that deserves to be asked and answered, but I think it's a desire to have in a clinical trial as uniform a population of patients as you possibly can so that you can, make accurate comparisons. But we as the academic investigators don't always make those rules.
I understand that. And in addition to that, many of the anti-PD-1 trials right now are asking patients be only those that failed IPI. So I imagine the logic is, again, having a uniform population that as well.
I don't think that's a universal requirement. Some of the trials have enrolled patients who had prior ipilimumab. Some of them were treatment naive. So I think as we get more and more trials and larger trials, those exclusions will not be as common.
Okay, well, good. What do you think about the interaction between the TIL therapy IPI when administered separately? Like, what order might they go in if you decided to?
I don't think we know yet. I think that there are actually good reasons to think about it both ways. There are reasons to think that if you gave an immunotherapy like an anti-B1 or IPI, or perhaps it would enhance the quality of the cells that were taken out of the patient and expanded. And conversely, you might imagine that it could help the cells once they are infused. So I think it's a wonderful question of how to integrate those two therapies, and I think that would be a very meaningful clinical trial design to compare modulation before or after.
Mm-hmm. I think it's pretty small though for TIL so far because it's so expensive, but they seem to be expanding. I know the Netherlands is expanding, so they're expanding overseas as well as here. And it came up, keeping on the TIL therapy line, the idea of using PD-1 instead of IL-2. Have you come across that as a possibility?
I have not come across that yet. I'm sorry.
Okay. It was Jeff Weber had brought that up, that he thought that might be in the future. A lot of
possible.
people are afraid of IL-2,
Mm-hmm.
Okay. Is there a correlation, and we get this question a lot, between the response to IPI and a response to PD-1?
That's a great question. That is a great question. So the good news is that just because somebody does not have a favorable response to one of those medicines doesn't mean they cannot respond to the other. So that's actually one reason why some of those trials deliberately enrolled, a uniform population of patients who did not have an adequate response to IPI to try to answer that question. And so I think the percentages are still a little bit of a moving target, but it's absolutely clear that there are people who did not do well with IPI who responded to PD-1, and now I think we're actually beginning to see, some people who did not have a great response to PD-1 who could respond to IPI. So it is very fortunate that there is not sort of a uniform immune sensitivity, right? Because one medicine doesn't work doesn't mean that the whole idea of having an immunotherapeutic response is out for that type of patient.
Great. Yeah, the question really comes up a lot.
Yeah, it's a really good one.
Mm-hmm. And I think in the beginning, we were all were under the impression that if you failed IPI, then you might as well forget the PD-1. So it was sort of a
I think that's fortunately not true.
Yeah. Soon, do you think PD-1 will be available or be approved?
I'm not that smart.
No, we're all guessing. But they're moving pretty quickly trials right now. I mean, the trials have gotten
It's
big.
hard. Yep, exactly. I mean, I think that everybody is moving very quickly. The whole PD-1 field has been, really in high gear. A couple of phase 3 trials being planned. One of them recently opened, and the fact that there are multiple PD-1 drugs, one organization spring on the other, it's all very healthy competition because it could potentially get medicines into physicians' hands to deliver to patients faster.
Competition, we like that. Yeah. There's 4 right now. Is that right?
Yep.
4 PD-1s. Great. And also another one that I really don't want to know the answer to. Did the amount of side effects for IPI correlate to its efficacy? So if people praying they get diarrhea,
Yeah. So the short answer is yes. That people who have side effects are more likely to have benefit. But what I tell patients is that you don't have to perforate your intestine in order to get into that category. You could have something as simple as some itching and put yourself in the category of having a side effect. So I don't think the severity of the side effect is related. It's having it yes or no.
Mm-hmm.
Pray for diarrhea. You can pray for some itching instead.
Oh, that'd be better.
Yeah.
It seems that treatments are given once a tumor progression occurs. This is an adjuvant question. Are any treatments designed to prevent these from happening? So
it is actually involved in at least 2 adjuvant trials currently, and so we'll know the answer to that question hopefully in the next year or 2. It's a great question, and I think there are reasons to think that it would be better to offer it in the adjuvant setting because people are healthier. The tumor may not be growing as quickly. They may be able to take the side effects better. But on the other hand, if there are patients in that population who don't have any melanoma, right? We know that, not everybody who's in the adjuvant setting is going to recur. There's some people who are cured with surgery.
Right.
That people are being given a medicine which has a very very interesting side effect profile, in terms of the ability in some people to cause some quite significant side effects. And if they don't have any melanoma in their system, then those patients are being exposed to a therapy which could harm them without any possibility of helping. So it's one of the challenges of offering medicines like this in the adjuvant setting.
Right.
It's not unique to this because any adjuvant chemotherapy question has to address that same kind of balance, that there's a baseline level of curability in the population, and you're trying to adjust that level of curability higher, but that there are some people that you're treating in some other diseases with chemotherapy, for example, and exposing them to risk, and they're never going to relapse anyway.
It's a really difficult area in melanoma because we have a wealth of patients who really have no options.
That's
right now. Because I actually have patients, who are stage 1 who would be willing to take an adjuvant, therapy, because they just don't want it to come back. This is along the same lines, but I understand that Ipi now can be given to stage 4 NED resected patients. Is there any evidence that this is working?
I don't think we have any evidence yet. You'd need long-term follow-up to answer the question, of people treated in this setting. And technically, I don't even know if the FDA label, includes people without evidence of disease, but I'm quite sure it's being done.
Yeah, I asked our scientific board member the other day about this, and he said that it was allowed to in that scenario, but we don't know if it's working. So people aren't really being followed, and they're really in a trial to how this works. Is that correct?
There's a trial. There is a trial.
And they should be with all of the approved drugs.
There could be.
Yeah, because that's more value when affected. How they're more likely to recur. Person wants to know. It said these drugs stimulate the immune system to attack the melanoma. Is there potential for the immune system to become exhausted from stimulation?
Question. I think that there is that possibility, and that's really one of the ideas of using PD-1 perhaps after Ipi or in combination with Ipi, because the PD-1 molecule itself is a marker of T-cell exhaustion. So perhaps either anti-PD-1 or PD-L1 after or with Ipi is a way to try to prevent that exhaustion. But it's a great mechanistic question that we don't yet have an answer to.
And what would you define as a durable response?
Oh, that's a good question too. I think if somebody has a tumor that either stops growing or shrinks or goes away for more than a year, to me that's durable. But I think everybody's going to define this differently. There are a lot of very words that use in this field. So durable response, cure, remission, disease control. They mean different things to different people. There's one right answer.
Right. And someone wanted to know about interferon and IL-2. Like, why are they considered immunotherapies when they're so toxic?
Okay, so I think this is a terrific question, because a lot of people would rightly think that, well, if something is activating your immune system, how could it possibly be toxic? Well, our immune system again is an organ system that is meant to have a toxic effect on invading pathogens and also to clean up diseased areas. And so sometimes the hormones that the immune system uses to kill foreign invaders like bacteria or viruses, or to clean up tissue, can be actually toxic on their own. The symptoms that you get when you have the flu are actually not from the flu virus directly, but rather from the significant amount of interferon that your body is making to try to kill the flu virus. side effects that you see when you give large amounts, much more than normally found, of these immune hormones like interferon or IL-2 into the system, sort of just magnifies or exaggerates the normal biology of these substances which float around in our blood all the time.
Do you think there'll be a place for interferon in the future for therapies with all of the other things coming along?
Could be. I mean, I think there's a lot being learned about the importance of interferon in terms of starting immune reactions. I mean, Dr. Kirkwood did a very interesting study combining another CTLA-4 blocking antibody called tremelimumab with interferon. Had some very interesting early results. So I think there really is a role, and there's no question that interferon does delay recurrence in the adjuvant setting. I mean, I think that we wished it would work better in terms of prevent recurrence. But, you know, I think that there's a role for it as an immune modulator. We just need to keep, again, constructing thoughtful combinations.
Right. That is going to be the key. Been a wonderful information, and I apologize again for all the technical problems we ran into, but apparently that's the nature of technology today. So thank you so much, Jedd, for all of your time and your wonderful answers and educating our patients today.
Thanks. I'd like to, first of all, thank you, Catherine, for, again, putting together this wonderful series and for the really terrific organization that you run. And, again, I'd like to thank all the patients, their families, and their friends for the tremendous support for the organization, for your attention today, and most importantly, for trusting us to help take care of you.
That's wonderful. Thank you.
Bye-bye.
Bye.